Good afternoon, everybody, and it is just afternoon. So welcome to this webinar from CHF in the series of CHF talks. We're going to talk about e-prescribing today, which is something which is coming to a pharmacy near you in the future, and I think is part of our commitment to promoting the ideas behind digital health. And during COVID, we've all had to adapt to new things, and I guess e-prescribing is going to be one of those. I have a group of panelists who you can see on screen. I'll introduce them as we go through and work through the program. Before we start, I'd like to acknowledge the traditional owners of the land that I'm meeting on, which is the Ngunnawal people, as I'm in Canberra, and acknowledge and respect their continuing culture and their contribution to the life of Canberra and the region. I also acknowledge and pay my respects to their elders, past, present and emerging, and to any other Aboriginal people who are on the webinar today. And some of our panelists are in different locations, so we acknowledge the owners of the land on which we're all gathered in our various places today. So thank you. The first part of today is going to be a presentation from the Australian Digital Health Agency, who have the responsibility for implementing e-prescribing. Nicola Graham is the Provide Adoption Lead Partnerships and Clinical Use in the Office of the Chief Operating Officer of the Australian Digital Health Agency. It's always such a mouthful, some of your titles, but that's all right. And Nicola's going to take us through, if you like, e-prescribing 101, and she's going to, so welcome Nicola, and over to you.
Thank you so much, Jo. That's a wonderful introduction. And it is quite a mouthful, isn't it, our titles? All right, Jo, I'll just try and share my screen. Just give me half a moment.
Yep.
All right. Now, can you all see that okay?
Yep, that's great.
Wonderful. All right. So let's just tell you a little bit about the National Digital Health Strategy, which is a 4-year strategy going through to 2022. Now, the agency has already delivered key pieces of work across these 7 initiatives. And the key priority of the Medicine Safety Initiative is, of course, electronic prescriptions. Now, the aim of electronic prescriptions is to ensure that there is a digitally enabled paper-free option for medication management in Australia. So what do electronic prescriptions mean for a patient? It will mean it provides a greater choice for a patient whilst maintaining patient privacy and integrity of their personal information. And electronic prescriptions is really basically an option for a patient to receive an electronic prescription as an alternative to a paper prescription. Now, there was changes to the Commonwealth legislation that commenced in October last year that recognised an electronic prescription as an alternative legal form by which medicines could be supplied under the Pharmaceutical Benefits Scheme. Now, each state and territory have been working to get the legislation passed. Now, as a patient, you'll be able to choose between a paper or an electronic prescription. And it's important to remember that electronic prescriptions are not mandatory, so there'll always be the choice to have a paper prescription. So I'm going to go through with you now the 2 models of the electronic prescriptions. Firstly, the token model. Now, this will be a unique QR code, which will be the evidence of the patient's prescription, and it's not the legal document. It's just the manner in which the electronic prescription can be sent. The patient can choose to receive the token via SMS or email, and I will go through a little bit later some screenshots that will show you the end-to-end process from when the doctor generates the electronic prescription to then having it dispensed at the pharmacy. Now, with the token model, you will get 1 token for each medication. So if you take, for example, Notin, Lipitor and Covasil, you will get 3 separate text messages or emails containing the token for each of those medications. Now, the second option, which is the active script list. Now, this is a more complete solution and will primarily overcome the issue of lost tokens, and it'll be suitable for those on multiple medications. Now, the patient will have to provide consent to enable the prescription to be stored within the active script list. Then they will be able to have the doctor generate the electronic prescription and send it to be stored in that list. Now, to get the medication dispensed, they will need to provide identification, and then the pharmacy will be able to retrieve the patient prescription details from the active script list and then dispense the medication as normal. Now, remember, once again, it will always be the patient choice. So if you prefer, you can still receive a paper prescription. Now, this slide outlines who can participate and use electronic prescriptions. We've got prescribers and dispensers, and of course, software providers and patients, and they all have a role to play. However, it is the patient at the centre of this, and it will be completely up to them if they'd like to choose to have a new prescription as an electronic prescription. Now, there are a couple of things to note. For prescribers and dispensers to be able to generate and dispense a prescription, an electronic prescription, they will require the capability within their software. And a patient must have an IHI, and that's an individual healthcare identifier in order to participate. Now, everyone who has a Medicare or a Veterans Fair card will have this given to them automatically. You probably already have one now. A patient will also be able to choose to have either an electronic prescription token or a paper prescription, but you will not be able to have both. And if you've already got an existing paper prescription, you won't be able to get this converted into an electronic prescription. Now, to ensure the smooth rollout of electronic prescriptions, they're being progressively rolled out through a number of what we call communities of interest. Now, this will ensure that any technical or workflow issues are addressed on a smaller scale, and the broader rollout will take place as more software providers progress through their conformance testing. Now, to be a community of interest, they must have at least one general practice and one community pharmacy that are close by each other who are electronic prescription enabled. And you may have all heard the first community of interest was in Anglesey in Victoria, and they successfully prescribed and dispensed an electronic prescription token for a patient. Now, of course, there are many more of these communities of interest who are participating, and they've been successfully rolling out the electronic prescriptions in their communities. Now, in regard to the active script list model, we do expect those to be included in the communities of interest from around August this year. And of course, then there'll be a progressive deployment of electronic prescriptions in a steady and managed approach. And this will be really expected by September this year. Now, to give you an idea, this is an electronic prescription workflow example to help you understand what it might look like. Now, this is just one example, and this focuses on the token model. Now, after your general practitioner has prescribed the medication, so all of your medications, this is when they will ask the patient if they prefer a paper prescription or the electronic prescription. And these are some examples of what a message might look like when the patient chooses to have the electronic prescription token sent to their phone from the doctor. Now, this is using the token model. Now, the doctor, whoever's prescribing the medication, will confirm that you have received your token via email or SMS before ending the consultation, or they'll advise you to call them back if you haven't received it. Now, in this first image, we can see the message is contained in the list of your normal text messages, and it says your prescription. In the second image, it shows a notification of the electronic prescription has been received and that it has an attached token in the form of a QR code. And then you can see in the third image, there are some specifics of the actual prescription received. At the top is the patient initials. Then you can see medicine name and strength. And this one you can see amoxicillin 500. You'll be able to see the supply remaining, which indicates how many repeats are available left, the QR code itself, and then also some QR code specifics. And this example shows what it would look like when you receive an electronic prescription via email. Now, you can see on the left side of the screen, it shows a link to access the QR code. And on the right is an example of a paper token. Now, a patient could print this out and take it in to be dispensed. So then, how does it look at the pharmacy end? When you take your prescription to the pharmacy staff member will scan the QR code, and then that will retrieve the electronic prescription from the prescription delivery service. Now, there will be options for the patient to either take this into the pharmacy, or you might be able to forward your token or email to the pharmacy. So they may have email or SMS systems installed to be able to enable them to be able to receive the tokens in this manner. Now, the pharmacy then can proceed to dispense the electronic prescription through their software and supply the medication to the patient as normal. Now, if your prescription has repeats on it, the patient will receive a new token that's sent to their phone in the same method that it was sent previously. So if you received it before via email, you'll receive the repeat in the same way. So then these are some examples of what you might see if, for example, in the first one, you can see the script has expired. And the second one, if it's already been dispensed, or in the third one, it shows it has been cancelled by the GP. Now, in all of these examples, there is no QR code displayed. And that's because in all of these instances, the QR code is invalid and it won't actually appear. It just really displays the relevant message. Now, this may look a bit different depending on what sort of delivery services your GP uses or the pharmacy uses. So let's go through some simple things that a patient can do to get ready for electronic prescription. So firstly, when you check in for your appointment, it's really important that you make sure all your contact details are up to date. Now, as the mobile or email that's listed will be the one that the token will be sent to. And if the patient has a carer, they can also provide these details to the receptionist to be added into their personal information. A patient can choose to have a carer receive the electronic prescription token on their behalf. Now, the patient should also contact their pharmacy to see if they are electronic prescription ready, or when they arrive for when you arrive for the appointment at the doctor's, just ask the receptionist if they could check with your preferred pharmacy to see if they're able to receive the electronic prescription. Now, as I said before, it's really important because if the patient's preferred pharmacy is not enabled for electronic prescription, they won't be able to dispense that token for you. So until your preferred pharmacy is electronic prescription enabled, you will need to have a paper script. Now, during the appointment, the doctor will prescribe the medication and provide you with a script. And it's at this time that you'll be offered either a paper script or an electronic script. And you will be able to choose to have it either sent to you via mobile or SMS or email. Now, this is again why it's so important to make sure that your contact details are up to date. So anytime you make a change, make sure you update that detail. When the electronic prescription is sent via SMS or email, it's instant. So while you're with your doctor, you should have received the token. If you don't have your phone with you or it's not close by and you can't check to see if you've received it, the doctor will ask you to call the practice and let them know. Now, if this happens, the doctor will be able to resend or cancel the token. Now, remember, when the script is cancelled, the original token that was sent will become invalid. So no one will have access to the medication or prescription details of that original token. So next we need to get the medication dispensed. Now, depending on the circumstances, the patient could take the token to the pharmacy, like you saw before, and be scanned, or alternatively, you could SMS or email the token to the pharmacy of choice. Now, it's important to know that the token with the QR code is really just a key that unlocks the electronic prescription. So that token by itself is not the legal prescription. It has to be unlocked by the pharmacy, who will then be able to dispense it. The token message is open to reveal a QR code, and the QR code is then scanned by the pharmacy, who retrieves the script details and then dispenses the medication as normal. If the pharmacy doesn't have your medication, the token won't be dispensed and you will be able to take it or send it to another pharmacy. It's not until the electronic prescription is actually dispensed and you have your medication that the token then becomes invalid. So if your prescription has repeats, once the pharmacy has dispensed the medication, they will send you an updated token to your mobile or email. Now, since the original token had been dispensed, it will then become invalid. And to get your repeat dispensed, you'll need to show your updated token that you received with the repeat prescription. Now, for those patients who normally keep their scripts on file at the pharmacy, obviously the ideal solution will be the active script list model when it becomes available later this year. But in the interim, if you want to keep your scripts on file at the pharmacy will be able to print a paper copy of the token and file it just like they would previously for your other prescriptions or your paper prescriptions. So we have a number of common questions that come up, and the first one is, what happens if the patient accidentally deletes their token? And we know how easy it could be for a patient to delete the token message, the SMS, or even the email. Now, the patient should call the practice and let the receptionist know that they have either not received the electronic script, or they've accidentally deleted it. The receptionist will be able to update the details, make sure that all those are correct, and send a note to the GP. And the GP will be able to resend you a new token. So what happens when it's sent to the wrong email? Once again, the GP will be able to cancel that token, the script, and generate a new script with a new token. And once again, once the original token is cancelled, it will become invalid, so no one will have access to that medication or prescription details. And then the third one is the patient is unable to receive an electronic prescription token as they don't have a smartphone. The patient may provide their carer's contact details, and as I said before, the carer can receive the token on their behalf. Or remember, they can always choose to have a paper prescription. So to communicate electronic prescriptions, we have developed a toolkit that contains targeted digital and print resources for practices and pharmacies so that they can advertise their electronic prescription readiness for the patients. Now, there are some different types of communication materials for practices and pharmacies who are looking at starting electronic prescriptions. So you might see a poster or a window sticker that says electronic prescriptions coming soon, or rolling out now, or we are electronic prescription ready. You'll also see advertising on digital mediums, for example, like Facebook. So that concludes my presentation, and I'll hand back now to Jo. Thanks, Jo.
Thank you, Nicola. There are a couple of questions in the chat box, which I'll go to first, which are clarification questions, and then I'm going to go to the other panelists. And people can use the Q&A section at the bottom of the screen if you have a question. If you want to put it up for us, for one of the panelists to answer, just type it in. There's a couple of questions that have come up, I think, that are clarification, Nicola. One is, can people have a paper script and e-scripts at the same time for different medications, but can they have a mixture, or is it a sort of, once you go into the e-script, you're into the e-script?
No, that's a great question, actually. So if you've got an electronic prescription, you can only keep that electronic prescription. But if you've also got a paper prescription previously, so in the examples I used before, we had Noten and Covasil. So say you've got a Noten prescription, you've got repeats on that, you'll just keep that as a paper prescription, and then you might choose to get your Covasil via electronic prescription. So you'll have a token for that. But what you can't do is you can't convert that paper prescription into an electronic prescription.
Yeah, and following up from that, can I just ask a question that comes up sometimes, which is, this is not just for general practitioners, is it? This is for specialists as well. So consultant physicians will be able to, and dentists and things will be able to do e-scripts, is that right?
Yes, so look, what it really is, it's around having conformance software. So as I spoke before, they have to have a specific software to be able to enable the electronic prescriptions. And there are a few criteria that they must meet. So as long as they're able to meet those criteria, then they most certainly would be able to prescribe an electronic prescription. Andrew, did you want to add anything to that?
Sorry, just going off mute, as we always do. No, Nicola, that's spot on, absolutely. I mean, it is dependent on the models and the solution architecture, or the way the system all works has been for all prescribers. So we know that there's obviously nurse practitioners who can prescribe, and dentists, and some podiatrists, for example. So that we've been agnostic on the type of prescriber, as long as they are a recognised prescriber, but it does depend on the software that they have. So I think some dental software may be some time off before it actually has that capability. So that's exactly right. But some of the software systems that specialists use are the same as what GPs use. So they would be able to progress that.
Yeah, there's a couple of other questions in the question box, in the Q&A box. One is, will a used prescription be deleted when used? So will the token be deleted once somebody's had the script
Yes, so
Yeah.
absolutely. So once that prescription has been dispensed, that QR code then becomes invalid. And like I showed before on that screen, you'll see that it just has, it's either been dispensed and so there's no QR code available, and the repeat token will be issued that will then have that QR code. So once you have already had your prescription dispensed, if it's just a once only medication, once it's dispensed, that token then becomes invalid.
And another question is, what's this, and a couple of people seem to think this is a good question. You mentioned the states and territories are passing legislation. Have they all managed to do it? What's the status of the states and territories moving to legislate for e-prescriptions?
I could probably answer that one, Joe. So you're right. The changes are at a PBS Commonwealth level. So the Commonwealth obviously manages the PBS, the Pharmaceutical Benefit Scheme, and regulations have been changed at the national level for that perspective. But the actual legal requirements for how a prescriber and a dispenser manage a prescription and what are the details within a prescription come from state and territory drugs and poisons legislation or the equivalent. They do vary in what they actually call, but they do the same basic things. So what's happened is that there's been a lot of changes that have had to be made at the state and territory level to recognise the form of the electronic prescription. And some states had already done that. South Australia only gazetted their regulatory changes on the 18th of June, and Queensland is about another week or two away. They've progressed all the documentation. It is just going through the final approval process. It is an instrument to recognise the legal form. The actual regulation already allows a mechanism for that to be recognised. So it doesn't have to go through a parliamentary process as such, but there is a specific legal instrument that needs to be put into practice. So that's about, we believe it's a couple of weeks away. So at that time, then every state and territory in Australia will be enabled legislatively for electronic prescriptions.
Okay, thanks, Andrew. And that's, I didn't introduce the panelists yet, so I'll do that now. And that's Andrew Matthews, who's the Director of the Medicine Safety Program at the Digital Health Agency. We're going to go to hear from our panelists, and then I'll go back to the questions, which are coming in thick and fast and are all good questions, I think. So we'll try to answer as many, and some of the, I think Nathan might touch on a couple that have come up about reimbursement and workflows for GPs. So he might touch on that. And some of the questions might get answered as people go through. First of all, we have Julia Nesbitt, who is a consumer and who's been active in CHF's digital health work. She's previously worked for the National E-Health Transition Authority and at the AMA, where she looked after e-health. So welcome to Julia. Lily Pham is a hospital and community pharmacist and currently works at the Pharmaceutical Society of Australia, where she's providing support to the electronic prescribing unit. So welcome to Lily. And Nathan Pinskier, who is probably known to some of you on the webinar, is a GP and practice owner, former chair of RACGP's e-health expert committee, medical director of the Doctor Locum service, and current president of the General Practice Deputising Association, and has had a long interest in e-health from a GP perspective. So welcome to those. I'm going to start with the consumer because we're the Consumer Health Forum. So I'm going to start with Julia and say to Julia, what do you think are the key opportunities and challenges, I guess, of e-prescribing from a consumer perspective?
Well, just a comment first before I start on Nicola's presentation. While she emphasised that an e-prescription or a paper prescription is optional, the reality is, given the investment that's been made in e-prescribing, there must be an aim by the government to increase uptake of e-prescribing. I mean, it's got to be worth the investment. So uptake's going to be important, I think, in terms of moving this along. Look, overall, there's no doubt that moving to e-prescribing is a logical step forward. And I understand there's some clunkiness is always a feature in the initial periods after rollout. But the key to success of e-prescribing is going to be based on consumers' seamless access to their medications when they need them. This won't be achieved, I don't believe, until the overwhelming majority of pharmacies are hooked up to e-prescribing. And this isn't just an issue of convenience, but also more importantly of clinical safety. And I think a couple of people have raised these sorts of questions too. There are numerous scenarios where issues of clinical safety arrive in terms of access to medications. You need a prescription urgently. Your regular pharmacy is closed down the weekend. You go to another pharmacy, they're not linked to e-prescribing. And in this case, the consumer cannot access their possibly urgent medication without trying to find a pharmacy that can access prescription through e-prescribing. So this comes down to making sure that the overwhelming majority of pharmacists are hooked in. In rural and remote areas or where people are travelling, this is going to be problematic. One experience of not being able to access your medication when needed will turn consumers right off using the system altogether, particularly where the paper-based system works really well. There are areas of the health system where e-prescribing will be of added value, and in one particular is aged care. GPs have to attend aged care homes to provide a prescription or change a dosage. So e-prescribing will be a significant value add for GPs if they can issue the prescription to the aged care facility through e-prescribing. And at present, aged care homes hold patient prescriptions and fill them for residents. So it doesn't change the basic process. In this context, there is a need to sort out issues around sending tokens to the aged care facility, particularly because this is one real value add that I can see for GPs to participate in e-prescribing. But this is also a value add for patients in ensuring improved GP access, where GPs are frequently absent from their practice visiting an aged care home for, say, an hour, simply to write an ongoing prescription or dosage change of an existing script. And related to this is the issue of carer access to e-prescribing, where they require the carer is required to collect another person's scripts. It's raised a number of issues around access to the token that are quite complex, and I won't go into it here, but it is another really important area. I think the other area that may cause confusion is for consumers that have multiple events across the healthcare system and then multiple prescriptions. For example, GP, hospital, consultations, chemo and specialists. And I know this was raised by one of the questions too. And the reality is that hospital and specialists are largely in the dark ages when it comes to e-health. And my own experience is that doctors in hospitals are still handwriting scripts and imaging referrals, as are many private specialists, some who don't even have Medicare Easy Claim. So the reality is, unless the broader health system is brought into e-prescribing, many consumers will be juggling paper and electronic prescriptions. And this is likely to cause some confusion, particularly for those with high medical and medication needs. And while it is optional, while, as Nicola said, it's all very optional, ultimately that option is likely to likely want to end that optional nature of it. So I think it's really important to focus on the access issues, some of the issues I've raised here, because I cannot believe that massively increased uptake is really also an aim.
Thank you, Julia. Excellent. And I think, yes, I mean, the option and the choice and the how long we keep paper scripts for, I think is a question which many people would like the answer to. I might go to Lily next. And Lily, from a pharmacist perspective, and you give advice, obviously going to be giving PSAs working with your members, what are some of the challenges and what are some of the opportunities from a pharmacy perspective as the dispensers?
Yeah, thank you for that. And thank you to Julia as well. She's shed light on a lot of important topics there. I think one of the main things for pharmacists would be administration or admin time in regards to processing a paper prescription. I think generally having things in an electronic prescription form will definitely help streamline processes and allow also time with the patient more so. And I know Julia had touched on, you know, some of that clinical safety aspect, and hopefully with the the electronic prescriptions, we're more able to streamline that, and also spend a lot more time with our patients as well. I know there was a question in the Q&A panel where someone had asked if electronic prescriptions were going to be available to those who weren't going to have specific access to pharmacy, so they couldn't go into a pharmacy. And this is where electronic prescriptions will particularly be advantageous in that perspective. So you'll never need to have the doctor or the patient you know, drop off that prescription to the pharmacy itself, and that can all be managed through post, through delivery, and obviously through SMS and email as well. So I think currently where we're at, it is a little bit confusing at the moment because we're kind of transitioning through all the conformance software and the systems. But once that all goes into play, I think it's really important for patients to be able to have that choice between paper and electronic. I don't think that necessarily paper is going to be gotten rid of. There are a lot of populations out there that are more comfortable with paper, and even when we saw prescriptions become typed up and photocopied, typed up, you still have handwritten prescriptions available. So I don't necessarily think that that's going to go away, but this is just another option for a patient to be able to access their medications, is all.
Thank you, Lily. And Nathan, from the prescriber's perspective, what do you see as the challenges and the opportunities?
Thanks, Jo. Look, I see this as an extremely important initiative. It's certainly something that when Julia and I were at NETA, we worked on extensively in 2010, 11, 12 as part of the Core Foundation services. It's important from a quality perspective, from a safety perspective, and ultimately from an efficiency perspective. But there are a number of critical issues, and they've been touched upon by both Julia and Lily. Ultimately, for this to work, this is really not about technology. It's about change and adoption. The process needs to be complementary, not disruptive. It needs to align with existing workflow. It's got to be something that really happens under the hood and is essentially seamless. In the same way, when I order a pathology request today, I get an electronic transfer of that information that's sent up the line to my pathology provider. And when people ask, well, isn't that fantastic? What do your doctors think about it? I say they don't even know it's happening because the electronic order goes straight to the pathologist. It's just part of the process of generating a pathology request. So this shouldn't be about technology at all. And unfortunately, what I'm seeing in the current e-prescribing model, and I think this is a view that is shared by many of my colleagues at the RACGP, is that the model as it's currently framed is far too complex, and the other speakers have made the same comments. The decision tree is too complicated. The current model of generating a prescription essentially involves you make a choice about what medicine is required or what repeat is required. The doctor writes the script, click the print button, it prints out. Now we've got a decision tree where we need to ask the patient, would you like a newfangled QR token model or would you like an existing paper script? And the patient is then going to say, well, what does that mean, doctor? And in all reality, the doctor's going to say, I actually don't know, because it's not going to be clear to them at that point. So if we go down the QR code path and they have multiple medicines, because the active script list isn't in play yet, we're going to end up with lots of tokens, lots of tokens to manage, to be cancelled, to be replaced. And if it fails at any point, it flows back onto the busy practicing doctor who's going to say, this is all too hard. So what's likely to happen? It's likely that given the complexity of the current model, most doctors will default back to just printing out the prescription. I also note that the QR token does not include the dosage information, and patients are going to want something when they walk out of the out of the practice. They're going to want some information they physically have in their hand. So we need to work out how to best align this. I guess what we're wondering is, given that ETP exists today, there is a barcode on the prescription at the moment, why we couldn't have added the QR code straight to the prescription and it appears on the prescription. That should have been a simple solution. It's what happens when you book an airline ticket. You get a choice of how you want it. You still only get one seat. At the moment, we're asking people to make an election about something they don't clearly understand. And given that most GPs don't want to have to deal with the technology and the issues that are affected by the decision, they'll probably just continue to use prescriptions, the standard paper prescriptions, and most specialists will continue to use standard-based prescriptions. There are a number of other issues, and that relates to the cost of the SMSs, that if we use the SMS model, general practice is paying for that, and there's a question around why GPs should pay for that. There is a risk in terms of if we SMS to the wrong phone number or if we email to the wrong address, there's a privacy consideration. We need to think about a clinical safety consideration as well. I guess we're also wondering why the repeat information is not being sent up to My Health Record, given, as Julia made, we've got a sunk cost of over $2 billion now on My Health Record, while we're not sending that repeat information up to My Health Record. I think consumers would be surprised to hear that's not the case at the moment, and I guess we'd be keen to hear as to how that's going to be resolved. So a whole lot of issues that we think are legitimate issues, notwithstanding we think that the actual initiative is really, really important. We also wonder why, if it is as seamless and as simple as people are saying, why do we need the communities of interest? If we're rolling it out, we should be rolling it out nationally. Why do we have to go through a sort of convoluted process, which suggests there are a lot of issues that still need to be worked through. And again, not here to be critical, not here to be oppositional, but we do want to understand why it is that we are where we are and why the workflow considerations in terms of the impact upon the prescribers and the conversation with the consumers has not been fully developed.
Thank you, Nathan. And I think whilst just speaking as a prescriber, I think consumers would have many of similar concerns, and looking at the questions, some of what you've said, people are reflecting in their questions. I'm not going to ask the agency to respond to your comments because that will take up the rest of the time. But what I will do is go to some of the questions. And I think one of the questions that's coming up, which I think is a good question and does, I think when we talk about choice, it's clearly not just the consumer choice here, because the prescriber will have the choice to offer it. And as Nathan has outlined quite clearly, there are lots of things that will influence whether they're actually going to give consumers that choice. And one of the things that we at CHF are concerned about is that people don't think, oh, I can have one of these and I'll go in and my doctor must give it to me and my pharmacist must do it for me. So I think it's a consumer expectation issue, and that we're going to have to manage. And we need, if this is going to work, then we need both the prescribers and the dispensers to embrace it. And as Nathan said, it's not just the technology is the small part. We've got to get everybody adopting it, and we've got to convince consumers to the value of it. And what I'm seeing, there's definitely some questions about coming through the questions about this.
Well, maybe Joe, do you mind if I just sort of comment on that? I agree with Nathan that the change in adoption is crucial. It is not just a technology issue. I think the technology is pretty fundamentally okay. But there again, the change in adoption is really crucial. It's about people. It's about a big change in the way people access their medicines and their scripts. So that will take time. I think it is quite appropriate that it does take a bit of time. And this is really the very first, I suppose, the foundational piece for setting the consumer expectations and building on that now. So our focus primarily for the last 2 or 3 months, and let's remember that the fast tracking or the acceleration of electronic prescribing came about under an initiative for the COVID-19 National Health Plan. We would have been about 6 or so months away otherwise, but we felt that the government felt that it was an important opportunity over and above an important and safer opportunity rather than the image-based medicine supply that is very much an interim arrangement that is happening now. So it has been accelerated, and that's why we've gone to the token model first up. There will be a lot of consumer experiences that will be much more enhanced with the token model once the apps come into play, and they're not that far off either. But it is very early days, and I think like any electronic technology, so whether it be electronic banking or electronic boarding pass, some people will take time, and there's going to be first people who want to jump on board straight away, and there's going to be some who sit on the fence for a while, and there's some who want to take their time before they see it. So that's exactly why paper prescriptions still remain. So if I can just sort of lay that point that I agree with Nathan on a lot of things there, and I think that's why it needs to be a very slow and steady approach. But nevertheless, they are real and they are happening now in a very limited and environment.
Thanks. I mean, I think, and this is a question for whoever wants to answer it, but and I mean, would it have been easier if we had made it that instead of the token going to the consumer, they could have opted to have the token sent to a pharmacy, like straight from the doctor? Why is that not in play? Why is it going to the individual rather than to the pharmacy? And I'd be interested to hear from Lily whether the pharmacists would have preferred that or whether doctors would have preferred to do that. I'd be interested to hear from the non-agency panelists first about whether they think that that would improve take-up by anybody. What do you think, Lily?
I think with the model that's happening currently with COVID, it's perhaps a more logical and easily digestible step to have it be sent to a pharmacy directly. In saying that though, you've got to remember that consumers do want some level of choice. And so directing it, having a doctor direct it specifically to a pharmacy could be seen as also a little bit unethical if the patient hadn't elected that particular pharmacy. So in that way, having the patient receive the prescription themselves would allow them to, access the medication when it was the most convenient for them. So I don't particularly personally see a huge problem with that, although it may be a little bit confusing with that switchover from the COVID model currently.
Okay. What do you think, Nathan or Julia? Do you think that would help uptake if that had been an option?
I think it's risky in terms of clinical safety if it goes straight to the pharmacist. I mean, in terms of the consumer loses control of their prescription in some ways. And, if your pharmacy is closed, you have no access at all. So for the meantime, I mean, I'm sure there's a better way down the track. I think that the current model is probably the best. But can I just quickly go back to one little thing that Nathan was saying too, is this choice of which you got, whether you want an e-prescribing or a paper, consumers have to be able to make an informed choice, and that's what's missing. They have to know the risks the risk to them depending on their circumstances of opting for an e-prescribing. And I think that's really essential in giving consumers informed choice. Sorry, that was a bit off the...
So can I ask you, Julia, who do you think should be educating consumers on that? Who do you think should be giving consumers that information? Because Nathan is saying that people might expect their doctor, because their doctor's the one that's saying, I can offer you an e-script. Doctors, it's not part of the consultation. So who do you think should be giving that who do you think, and how can we give that information?
Well, I don't think doctors will want to do it, and it is complex. They do know the patient. I think there's lots of elements come into this. I mean, really, it's GP's time, so that raises issues of length of consultations, costs, etc. But there may be an ability to for the GP to say, you can have, I'll give you a paper prescription, but this is available for the future, and a really good sort of piece of information out from the agency that explains the risks, particularly for people on multiple medications, etc. So the agency, government provides the information for people to make an informed choice. And
we'll have different choices once we get active script lists and tokens in play.
Joe, can I just respond to the question about sending direct to the pharmacy? I think that would be a very poor outcome. The model that was developed over a decade ago was any script, any pharmacy. If GPs had to then select from a list which pharmacy, the chances are you're going to get it wrong. And as Julia said, the script will end up all over the place. The value and the benefit of having a prescription exchange service means it goes up to a central repository and it can be downloaded by any dispenser at the point of time. So it's a much better model than the current model we have with pathology and diagnostics, where you send a script to one, we send a test request to any lab, and then they go to another lab and it has to be regenerated. So having a centralized model is a much better model.
So you think having the script list? I mean, I think one question which has come up, which I'll start with the agency to answer, and is what are we looking at in the time frame for implementation, Andrew? That's not clear. You said, I think Nicola said, we're going to roll out communities of interest, and you said slow and steady. And then we have messaging from the minister, which says in 8 weeks, everybody will have it. What is the time frame for the national rollout of e-prescribing, both token and ASL and active script lists?
I think, thanks, Joe. I think we've, in essence, we've been delivered with what the government said. So within 9 weeks of the COVID-19 announcement, Australia's first electronic prescription was transmitted. But look, there is a little bit of variability in there. Our expectation is by August, the broader scale up of electronic prescriptions within the token model will be in place. But it is exactly around what those communities of interest electronic prescribing approach is about. The difference with the way a software vendor releases software normally is that if it's a general practice software provider or a pharmacy software provider, they usually have what they call beta sites, where they have identified general practitioners and pharmacies who are prepared to test their initial rollout of new software. The complexity in this situation is it's not just how it works at the pharmacy level or how it works at the GP level. The issue is that it's got to work from the pharmacy through the electronic prescription, the prescription delivery service, through down to the pharmacy, and then on to Services Australia for an actual PBS payment claim. So there's a real end-to-end process that adds a sense of complexity. So these communities that we've established to test and evaluate the electronic prescribing, it's all very well doing the test within one software system like Aid to Dispense software, but we've got to make sure that the flow through all works well. And the way we test conformance manages that to a certain extent.
So can I just stop you there? And I'm going to channel Virginia Trioli here and just get you to answer the question, Andrew.
Yep.
Which is, what are we looking at in terms of a time frame for rollout?
Yep.
So that the consumers watching this and people out there in the street can either expect to be offered this by their GP or be able to go in and ask for it and see posters up on their pharmacy and posters at their doctors. We are now doing e-prescribing. What are we looking at?
Right. The first step, I'll give you some caveats. I'll give you some caveats on it, but on the other hand, we're saying August, end of August would be the token model availability, and probably October for the ASL. Now, the only caveat I put on that, Joe, is that the communities of interest have been set up, and this end-to-end process is about picking any holes, picking any issues that come out of that end-to-end process testing. So if there are some things, and there have been a few little hiccups along the way, if the software providers feel that they've identified all those issues by the end of July, then we'll proceed within that current time frame. So that's the caveat that I put on it, is that the testing process is designed at an end-to-end level to make sure that we pick up any problems. So provided we don't, we're sitting at August for the token model and through to October for the ASL.
So that's national.
Yep.
So unless we are told otherwise as consumers, sometime in August, either the beginning or the end, somewhere in between. By the end of August, people would be expecting to be able to either ask their GP or their doctor prescriber, not just a general practitioner, be offered the opportunity. So that's helpful, I think, because that does. And I think some of the questions have been about the thing that I asked, which was about, there is some confusion about repeats here. And I think there's some confusion about repeats. Why multiple tokens for repeat? Currently, when you get a script, a paper script, you get it. I just got one the other day and it says 5 repeats. And I take mine into my pharmacy, and I'm a good person. I've got a regular pharmacy, and I actually get them to fill it, and I leave my script there, and then I can just order using an app, order the repeats to be got ready for me. Am I still going to be able to do that with tokens? And will I know how many repeats I've got? I mean, it just seems very cumbersome that you get 2 different, the way Nicola was describing, you get 2 different tokens, one for the original and one for the repeats. This is going to confuse consumers. Can you just clarify the repeat issue? Because I think that is a concern for dispensers, prescribers and consumers.
Nicola, do you want to address that, and then I can talk a
Yeah.
little bit more on.
Yeah, that'd be great. Thanks, Andrew. So remember what I said now, with the original token, once, like your prescription now, you take your original prescription into the pharmacy and they dispense that prescription and then they give you the repeat. It's exactly the same with a token. So you'll take your token, the original token, into the pharmacy, they will scan the token and it will be dispensed, and then they will issue you with a new token. And you won't have access to the other token. That's how it will be. So you don't actually keep both. And like I showed you in those little infographics, it just has a message. It doesn't actually have a QR code, so nothing can be scanned. And also with your prescription repeats, it will say at the top of that, so remember it had your initials, the medicine name, and then it says how many repeats are remaining. So you'll know what repeats are left, and it's actually on your token. So if you think about...
Hang on, so you'll get a new token.
Yep.
You get one, you get a new token, which you're going to have as a message on your phone, which you're going to have to keep for a month on your phone. Yep. Don't know about everybody else, but I'm unlikely to keep. Some phones delete messages after a month, so I think there is something there you might need. Well,
yeah. So if that does happen, Joe, absolutely, and we know that this happens from time to time, and I don't take very many medications, but I'm hopeless and I do lose mine as well. So say for example, you've got your second repeat and you went to Andrew's pharmacy and you said, I've lost my token. They can reissue you that token. So they can just resend it to your phone while you're there, and you've got the reissued token on your phone. So if you have deleted it, they can reissue that token to you.
And you can leave your script on file with a pharmacy, but they then have to transform it from a digital to a paper copy and put it on file. Is that correct?
So it will just highlight the QR code image, and they'll just print it like you would normally just print something. It's quite easy. And then they can just file it like they would your paper prescription.
I think that the repeat issue is actually going to cause consumers. I don't know what Julia thinks and what Nathan thinks and what Lily thinks, but I think this is where there is going to be enormous confusion. What do you think, Julia?
Before I let that happen, I just the active script list model will really be the better solution for those patients who are on multiple medications. And I guess what's missing here is it's really, really important to also remember that you can choose a paper script. You do not have to have the electronic one. So if it is difficult, that you definitely don't have to have that. You can still have your paper prescription.
Nicola, we just clarify with the active script list exactly who controls the app, how many apps will there be, and will the consumer have to sign up with one preferred pharmacy group or retail chain? And does that limit their choice?
Actually, the active script list is controlled by the patient, and they give authorization to the GP or the pharmacy to be able to access that. Andrew, you might be able to elaborate much better on that.
Who is providing the apps, just to be clear?
Andrew, do you want to answer?
Yeah, I'm
that
happy
one?
to have that. Look, so the existing providers of apps in the marketplace, you know that there's many chain pharmacies that have their own app. There's other examples, and just for the point of view, not sort of supporting any particular app, but just so that people know an example. But MedAdvisor is certainly, I know, working through that process, and I do think that will make the tokens a lot more manageable. I think you're right, Joe. The tokens will be useful for intermittent medicine supply, and especially under the telehealth initiative with the tokens for one-off medicine. The token, just receiving an SMS and getting it dispensed, will be practical. But nevertheless, for ongoing supply, I do think the capability of those sorts of apps will make the user experience much more functional. The active script list is within, if you consent to any health provider, that may be multiple pharmacies or it may be multiple general practitioners, then those health professionals can access your active script list, and you do have control through an app as to how long that person has access to your script list for, and your ability to view your script. So that's where the other app providers are working to manage that into the future. So we expect that a number of the existing app providers will also provide that opportunity.
Joe, there's in terms of this question of the repeats, I think for consumers, it's about having access to the same information that they have on their paper script. And maybe in the interim or whatever, when the patient receives their actual prescription over the counter, currently, you know, pharmacists will put on a label saying one repeat left. This is the last repeat. I'm wondering whether a simple solution, I don't know how simple it is, I know it's a bit of a palaver, but having put on that label on your medication saying 4 repeats left. So you've got the same information, but it's on the label. If you can't, you know, that's, if the token can't give that information to you, then you've got it there. You can just look at your, I mean, it's a simple solution, but, you know.
I might just pop in.
I was going to ask you, Lily.
Oh, okay. Good timing. So when the pharmacy does reissue a repeat prescription, it would be the similar format to how a doctor would issue an original prescription. So it still have the patient's name or initials depending on the state legislation. It would have the number of supplies remaining as well, the drug dose and the drug strength as well. So you wouldn't be missing out on that information at all. And usually with the medication on the actual label, there will be in little letters how many repeats are remaining, and that already exists.
Does it include
that would be able to.
Lily, does the QR code information include frequency, 1 TDS?
It does not include frequency.
So I think that that's a major clinical safety omission. So when a consumer at the moment walks out with a hard copy script, they can see whether they take it once a day, standing on their head upside down before breakfast, after dinner. On the QR code, it won't show that. The only time they'll know that is when it appears on the medicine they get dispensed. And they won't be able to match that up with the prescribing information because the QR code information hasn't got that. So if there's an error made at the pharmacy end, you will have a significant problem. And we need to rectify that. We need the dosage information appearing with the QR code. The QR code, I understand, is the electronic lock, but we need the paper written instructions so that people understand exactly what the human readable form is.
I think that's a really good point, Nathan. And I think, you know, I think for pharmacy as well, currently the paper script has a lot of information. Some doctors write extra things. I know my specialist, you know, some of the medications I've been on, it's start off by taking half for the first 3 days and do this and do that. And if X happens, try this. And it's all written on there. You're not going to have any of that on your, well, I know my specialist is not going to use them. So it's an irrelevance really. But I think for consumers, this is the issue. And if we're going to sell this and we're going to convince people to the worth of this endeavor, then we're going to have to answer all these questions. We are running out of time. We have got a lot of questions. I think what we're showing is that what we've probably prompted is people to ask more questions than we've been able to answer. We'll pull these questions together and we'll put together a sort of Q&A thing from this and try and get that together. And we'll talk obviously to the agency and to our panelists to get the answer. So if your question hasn't been answered today, it hasn't been lost. And we will put it up with the, we'll put up a question and answer thing. I think this shows that CHF has, and the agency and all of us have a lot of work to do to make sure that these questions are answered in what people want. I might just say, I just might give Julia, Nathan and Lily a chance to say their last summing up thought on this. If you had to do one thing about e-prescribing, what is it that you would do, Julia?
Well, I think that given what Andrew was saying about the timing of the rollout, I think it's absolutely vital that some consumer information is developed, and you might hate me for this, Joe, but in conjunction with CHF, I think it should be a joint enterprise that goes out to GP practices to hand out to consumers. I mean, I think this is absolutely vital to happen in conjunction with the gradual rollout August and October. You know, it's nothing out there at the moment, and I think it'll enrage GPs and it'll enrage patients if they get it wrong.
Okay. Lily, what do you think is one thing we should look at, one thing we should do?
Well, I think my team at the PSA is doing a great job so far. So what we're doing is we're really engaging with pharmacies in the community to get on board these communities of interests and really push the whole process forward. So I think that's really vital, getting all of that, you know, community awareness up and coming. And I think hopefully if we keep doing what we're doing, things will start rolling ahead.
Because you will be at the cutting edge when somebody comes in with their code and they don't know what to do with it. It's going to be your members who have to deal with it. So
exactly.
You have a vested interest in it being got right. Nathan, from your perspective.
So again, as I said, it's a really important initiative, but if we rush it, we run the risk of it going wrong. And if it goes wrong, we'll have all sorts of problems. So we need to align it with existing workflow so it minimises the impact on both prescribers and consumers. And we need to ensure that the clinical safety case is tight as possible. The last thing we need is a medicine's misadventure or a series of medicines misadventure. If we make the problem worse by introducing electronic prescribing, it will slow us down for many, many years. So what we need to ensure is that we provide the same information going forwards as the same information we provide today to a consumer. And that, I think, is a critical piece of work that needs to be closed out fairly quickly.
And that's a great place to end. So I'd like to thank I'd like to thank Nicola and Andrew from the agency for a great presentation. I think it started the ball rolling here. We've obviously got a lot more work to do, all of us working collaboratively, and CHF is working with the agency on the consumer messaging. And I'd like to thank our three panelists, Julia, Nathan and Lily, for what I hope was informative, and also to you for your great questions and for taking the time to participate. So thank you all very much.